Okay, now let's start on vignette number 2. Casey, part 1. Casey is a 24-year-old woman with no previous history of psychiatric treatment. She arrives in the emergency department, brought by her older sister with whom she shares an apartment. The sister came home from work to find Casey sitting in a chair staring straight ahead. She didn't answer when her sister walked up to say hello and ask how she was. Casey continued to stare ahead as if her sister were not present. After several minutes of not getting a response from Casey, her sister went to call their mother for advice. When she returned, she found Casey had stood up, gotten into a strange pose, and after about 30 seconds sat back down. Casey remained uncommunicative and continued to stare ahead. Sister called 911 and EMTs brought Casey to your medical center's ED. You are called to psychiatrically evaluate Casey. You find her lying on a gurney, looking straight up and not responding to your requests. Her expression is flat and without change. You take her arm and gently guide her to sit in a chair. She complies, moving slowly and without resistance. As you're conferring with the sister, Casey stands up and enters an unusual pose and remains motionless. You gently move her arm and her arm remains in the new position. The sister reports Casey is a graduate student in history and has been struggling academically and with her teaching load. She broke up with her boyfriend last month and has been increasingly despondent, looking worried and anxious at times and apathetic at other times. So what syndrome is Casey most likely suffering from? Choose one. Okay, cataplexy, catatonia, opisthotonos, stereotypy, or tardive dystonia. All right. I'm waiting. Okay, it's getting better and better. Good. All right, good. Everyone got it right except one person. Sorry, it's not cataplexy. It's catatonia. And one of the symptoms of catatonia is catalepsy. Catalepsy, not cataplexy. Cataplexy is part of narcolepsy, where you have that kind of like atonia, just dropping down because of REM sleep intrusion into wakefulness. That's cataplexy. I'm going to go over with you my mnemonic, right? So catalepsy, that's, I imagine a cat leaping, catalep. Cat leaping, kind of frozen, like stop action in some weird posture. And that reminds me that when a cat leaps in and is frozen in a weird posture, that has to do with catatonia. And the other one, cataplexy, that has to do with narcolepsy, right? Okay, it's dumb, but it works. All right, and again, that's another basically fact-based question. Not much there in terms of judgment. You either know it or you don't. Question 2, the syndrome identified in question 1 is most likely to occur in which of the following psychiatric conditions? Choose 3. Bipolar disorder, body dysmorphic disorder, major depressive disorder, schizophrenia, and or tardive dyskinesia. All right, everyone got this right. So there you go. Some of the questions on the exam are truly going to be easy. All right. Another thing I can tell you about the exam, and it's not by accident that this is the way it is that there's a range of questions from easy to hard. And some of the hard ones are so hard that like almost no one would know it. And in fact, that's why I've never heard of anyone getting 100% correct on their exam. Now, there are people who get, 100% correct on their SATs and ACTs and things like that, but on the psychiatry board exams, it doesn't happen. There's just always some questions that are just so out there that you cannot know them. But there's always enough easy and moderately hard questions to get you over into the pass category. So this is one of those ones that was not all that challenging to you. Good news. Which of the following are most likely to be symptoms of this syndrome? All right, we should get 100% correct here. Catalepsy, cataplexy, mutism, perseveration, pressured speech. Oh no, some people were not paying attention to Cat leaping. Cataplexy. Plexy is not a leap, right? Lepsy, right? Catalepsy. Cat leaping, frozen in a weird posture, right? All right, so the two are catalepsy and mutism. Perseveration is different. That's someone perhaps with a brain injury or dementia, who, when you're doing like a cognitive exam, whether it's formal neuropsychological testing or even kind of bedside testing, and you kind of change sets, like in the Wisconsin card sorting test, and people persevere. They don't change the set. They don't follow like the new instructions. They're persevering on the previous instructions or the previous kind of categorization system. I'm not going to get into that now, but that's not it. Pressured speech, obviously, that's bipolar, and then so mutism is it, and then the challenge was catalepsy versus cataplexy. Cat leaping, that's the one we want, catalepsy. All right. Which of the following are the most likely potential sequelae associated with catatonia? Sequelae. Choose 2: acting on command hallucinations, dehydration, hyperpyrexia, hypothyroidism, or hypoadrenocorticism. Okay? Let me give you on. Give you a little bit more time here. Again, how are you feeling? Feeling okay? Feeling frustrated? Angry? Afraid? All right. Dehydration and hyperpyrexia. So, in fact, before the advent of psychotropics, there was a rather high rate of injury and death from catatonia, because these people, would remain in their stupor, unresponsive. They wouldn't be eating and drinking. So before we had IVs or, NG tubes, these people could just really get dehydrated. And they could develop hyperpyrexia from maintaining that kind of, rigid muscle tone. So those are two important medical sequelae of catatonia. Acting on command hallucinations, it's hard to say that that's a possibility. There are, many reasons for catatonia, right? Not all of them have to do with schizophrenia or schizoaffective disorder. Which of the following disorders are most important to rule out of the differential for catatonia? Choose 2. A mixed mood state, myoclonus, neuroleptic malignant syndrome, serotonin syndrome, psychosis. Choose 2. Again, pay attention to your feelings. You're feeling confident, good, right? You're going to do subtractive approach or additive approach here. The most important to rule out for catatonia. Again, how do you choose? If you're finding like, well, but Jack, I want to choose 3 or 4. Pay attention to that, and then ask yourself, well, how do I differentiate? If I have to choose 2, I want 4. I don't want myoclonus, all right? Let's just say you don't want myoclonus, but I want the other 4. And I'm like, well, sorry, you're only getting 2. What can I tell you? You're getting 2. So how will you decide in your own mind? Is there another variable at play here that can help you decide? And there is. There is another variable. And you know what that variable is? What's most emergent? What can kill you? Neuroleptic malignant syndrome, serotonin syndrome. So those are in the differential. And you can have that kind of muscle rigidity that could be confused, that kind of lack of responsiveness, the hyperpyrexia perhaps, that could occur with either C or D. If there's anything that I want to be able to rule out now, most urgently, are those 2. Now, of course, I'm concerned, what's the catatonia is not a disorder. It's a syndrome that occurs with medical conditions, and it occurs with psychiatric disorders. And I want to know what the nature of the psychiatric disorder is, if in fact that is it. But is that the most urgent thing I need? No, because I can first treat the catatonia directly without even knowing what the underlying psychiatric condition is. But serotonin syndrome can kill you. Neuroleptic malignant syndrome can really hurt you, if not kill you. And serotonin syndrome develops pretty quickly too. Not only is it lethal, it's quick. Delivery of which of the following medications can help establish catatonia as the diagnosis? A kind of interesting question. It's not treatment. It's like, it's almost like using a medication empirically to help the diagnosis, right? Interesting. So IV valproic acid, IV lorazepam, IM risperidone, PO sertraline, or PO haloperidol. All right. Let me give you some time. Oh my God, I don't have to wait. Everyone got it right. Awesome. Awesome. Good. It's one of those easy ones. All right. We'll take it when we can, right? If a patient with catatonia fails to respond to lorazepam or another benzodiazepine, which second-line treatment should be administered? Choose one. ECT, transcranial magnetic stimulation, IV ketamine, IV brexanolone, IM risperidone. All right, you can only choose one. I kind of made this kind of easy for you, you know. I think that probably I was thinking that some people may choose E, but actually it's been found that the antipsychotics, you know, in meta-analyses have not been found to be effective in treating a catatonia. Now, if catatonia is part of a psychotic disorder like schizophrenia or schizoaffective, you know, then we do need to treat with an antipsychotic. But for the catatonia, it's going to be the benzodiazepine. Lorazepam is a good, safe choice. It has a medium half-life, right? It does not go through phase 1 metabolism. So if we don't know, like whether the patient may be either a heavy drinker or something, or may have hepatic damage. So, and it comes in different formulations, PO, IM, IV. So lorazepam is a good choice out of the benzos, although not the only one. All right, Vignette Casey Part 2, based on your diagnosis of the catatonic syndrome. Casey is extensively evaluated medically and no underlying medical condition is identified. She's then treated with 2 milligrams IM lorazepam Q4 hours for a total dose of 12 milligrams over the first 24 hours, right? Does that make sense? So every 4, that's 6, times 2, that's 12, right? Makes sense, 24 hours. Although Casey stumbles when she stands up, likely from the benzodiazepine, she otherwise is without change in her presentation. Oh, so anyway, that other question was misplaced. Sorry, we did this one. So we're going to choose ECT, right? So we went through that. So that's the end of the lecture. Feel free to email me at drjack@americanphysician.com, and I'll be happy to kind of anonymously share your responses. I'm very interested, and tell me if this has been helpful for you to kind of focus on your own cognitive and emotional responses and how you think this might impact you at the real exam. So thank you very much. Signing off, it's Dr. Jack. Thanks. Bye for now.